achievable, and they are for relevant and at the same time, they are very time bound. At present, she is director of Bapat Hospital, Indore. She is vice president Foxy 21-22, organizing secretary ICOG 22 in Indore. She is famous as one-day hysterectomy surgeon, and ICOG vaginal surgery course is conducted in her center. She is peer reviewer of Jogi, and Dr. Kawita has initiated registry of ovarian insufficiency, received healthcare awards from Dainik Bhaskar, received Nika award, then received Captain of Industry award. She is vice president and chairperson of the committee, and she is member of Urogynecological Committee, executive member of ISAR and IAGE.
Neeru, thank you. Thank you so much, Neeru. Neeru, thank you so much. This is a very our close program. We want that. Thank you so much. I always love you, Neeru, for nice and sweet words.
Over to you.
Thank you so much. Thank you so much joining Dr. Anupama, who is a very senior OBGYN from Indore, both, and same with Dr. Nirja Puranik, who has got a great love for breastfeeding. Thank you today for joining. And this program is very simple, as we all talk about that. This is learn simply tea time, because we don't want to waste much of the time. We want to then, but despite the significant changes into the management of labor and delivery over the past few decades, what I feel it, but operative vaginal delivery remains an important component. Am I right? And in the modern level, according to, it's almost 3.3% deliveries being the use of obstetric forceps or vacuum extractors are required. But we should be familiar with this and how to use the instrument, what risks are involved, and what is the purpose today of this topic is to provide the evidence regarding the benefits and the risk of the vaginal. So I'll like to share my screen and to do these things. So thank you so much for being with me. And again, as I told, this is a topic which is good operative vaginal delivery and important also. And we have two experts, Dr. Nirja Puranik and Dr. Anupama Dave today. They can give their point of views at the end, that when and why, because Dr. Anupama comes from the institute where thousands of deliveries, probably 4,000 deliveries a month. Am I right, Dr. Nirja? More than that deliveries she's conducting. So in that place. So that's the reason. So she'll give her expert comments on this. So everybody knows that I come from the Indore. That's not a big point. Now we'll discuss a simple case. Whatever this is like this. 2 years primary gravida with 39 weeks of gestation. And the first was according to the first sonographic scan. Admitted to the maternity ward for leaking per vagina. Examination, condition fair, pallor, icterus, dehydration or edema, nothing. Vitals were normal. Pulse, BP, temperature, everything normal. Respiratory rate normal. Per abdomen, uterus term size, cephalic presentation with mild uterine contraction. Fetal heart sound for 30 BP. The PV centimeter, os 2 centimeters, soft, unaffaced, posterior. Head station at 20, induced with 2 doses of misoprostol, keeping the posterior fornix and the after vaginal examination. Bishop scoring at 4 AM and 10 AM were recorded. So during the process of delivery, she got exhausted. The head is at visible in the ease. Efforts of forceps is applied with carefully mediolateral. Episiotomy taken, delivered, alive female perineum cervix explored, examine and tear. Episiotomy taken, stepwise, sutured. Then total duration of the labor 4 and 30 minutes, blood loss 100 ml, placenta normal type, baby's weight 2009. These are the cases which day to day we see and when to apply the forceps. But in these cases, the mother got exhausted and stuck, and that's what the reason. Apgar score normal, no blood received. Again, the second case is a similar type of case, 38-week gestation, admitted with a labor ward with a labor pain in night. Examination, general condition fair, same, pulse, BP, temperature, all normal. Uterus term size, cephalic presentation with mild uterine contraction. But she came with a 7 to 8 centimeter dilated, cervix well effaced, well applied. Head station 0+1, Bishop score. During the process of delivery, mother refuses to push down. Exertion leads to visible to ease the efforts. Vacuum is being applied carefully, and the mediolateral episiotomy was taken. delivered the alive female perineum cervix explode, examine the tear, episiotomy, total duration 6 hours, total blood loss, normal time. In both the cases, the different ones we applied the forceps and another we applied the vacuum, because operative vaginal deliveries are two other things, vacuum and this thing are more important. Now, why we have discussed these two very simple cases? One, we have applied the forceps and another we are talking about the vacuum. Now, what care should be taken? What are the informed consent? What are the timing for the instrumental deliveries are very, very important. So this today's, you can say, lecture or today's presentation about the operative vaginal delivery will cover these type of points. What care we have taken, what are these things. So the operative vaginal delivery refers to any operative procedure designed to expedite the vaginal delivery, including the forceps delivery and the vacuum extraction. These are the two important things. Now, indications for the operative vaginal delivery include maternal indication, very commonly maternal exhaustion, inadequate maternal expulsive efforts, women with the spinal cord injuries or neurovascular diseases, need to avoid maternal expulsive efforts like women with certain cardiac or cerebrovascular vascular diseases, they can have. Then indications for the operative vaginal delivery, the fetal indications such as non-assuring or reassuring fetal testing, like a baby is having a fetal distress, which we used to call it, and also now. Other indications such as prolonged second stage of labor can be nullipara, more than 3 hours without regional analgesia, more than 4 hours with regional analgesia, in a multipara, more than 2 hours without regional analgesia, and more than 3 hours with regional analgesia. Commonly in our country, we don't use the common females regional analgesia, we don't give it. So it's very, very important. The timing is very, very important. So the prolonged second stage is another important point. And there is elective shortening of the second stage of the labor using the outlet forceps. Sometimes we don't need the expulsion force, maybe not the size of the baby is normal, but we want to shortcut and that can be done electively also. So sometimes the placenta previa, absolute cephalopelvic disproportion, any other contraindication to vaginal delivery. So these are the basically contraindications for using the operative vaginal delivery. Prematurity is another one. So take it a point, very, very important. And if the membranes are intact and cervix not fully dilated or failure to obtain the consent, that's another important point. If we are not able to take a consent from the patient that we are going to use the forceps or anything, these are the real contraindication for using the operative vaginal delivery. These are the contraindications. Now, in 1988, ACOG classification is an old classification, though it's using forceps is probably I think last 40 years, I think it's basically gradually obsolete art. But we cannot, as the students, everyone should know it, that this is one of the things that everyone should know it. In a teaching institute, they talk about it, they do about it, and sometimes it's needed also. So it's another important. But the old category of the high forceps were placed with a fetal head floating below table above the brim. True pelvis has been abandoned due to the excessive. So forget about all those old types of key lens and all sort of forceps are no more uses. So forceps delivery is basically, this is the classification. We can divide into 3 points. Outlet forceps, scalp is visible at the introitus without separating the labia. Fetal skull has reached to the pelvic floor and sagittal suture is in the direction of anteroposterior diameter in the right or left occiput, anterior and posterior position. Number 1. So outlet forceps. The low forceps, fetal head is at or on the perineum. And mid forceps leading the point of the fetal skull, the station is +2 or more, but not yet reached the pelvic floor. So these are the basic classification. High forceps, the head is engaged, the pelvis is presenting above +2 station and basically not included in this classification. I'm just putting it. So this is not in the classification also. So the mid forceps delivery should be performed only by the competitive operators. A senior person like Dr. Nirja Puranik, Dr. Anupama, they have seen so many forceps deliveries that when they want to use the mid forceps and then the need of an expert is needed, then these are very, very important. But after careful consultation of the alternative approach. So another important point, oxytocin administration, cesarean section, and continued expectant management and the potential phase ways. So mid forceps, we have to be very, very clear about it. See, I have a few diagrams how to use it and when to use it. So indications for this is the forceps. Then the indications for the vacuum extraction, similar to those of forceps delivery, but there are fatal complications such as facial bruising, laceration, cephalohematoma, facial nerve palsies, skull fractures, cervical spine injuries, and intracranial hemorrhage are rare. But what I am saying, a person like me who was practicing for last 30-35 years, more than that, when we were students in 1983-84, we have seen everything. All will, Dr. Puranik will agree with me that we have seen the complications of forceps deliveries, everything. Even the hemorrhage with this written rare, we have seen the skull fractures, we have seen the cervical spine injuries, and really bad. We used to feel bad, but these are the complications of operative vaginal deliveries, and they are very, very important. And other than this, the maternal perineal injury, what happens? All the perineal muscles torn, all laxity. Again, in the future, there is so many things are there. So they are very important. And failed operative vaginal delivery is more common with a vacuum than forceps. So make it a point, another important point, and more common with a soft cup vacuum extractor than the rigid M cup. Previously, they had this cup, but now the soft cup being used. And where to put it? What is the correct placement of this? So when it should be keep on the flexion median point, basically, and flexion median point is basically 3 centimeter from the. This is the posterior frontinelli, this is the anterior frontinelli, and just close to the anterior border of the posterior frontinelli, and 3 centimeter from that, at that flexing median, the cup should be produced. And this is the all incorrect placements of the cup. It's a flexion paramedian or the deflexing paramedian or this also, so we should be worried about. The choice of which instrument used depends upon the clinical preference and experience. Very, very important. If somebody is able to use forceps more than vacuum, they should try for forceps or this. In some circumstances, one instrument may be preferred over another. So it is another important point. Vacuum extraction can be accomplished with minimal maternal analgesia, and vaginal murk is more likely to be achieved with forceps than with vacuum extractors. So make it a point very, very clear. So failure of vacuum is more chances than this. Then exact knowledge is essential to prefer the forceps application. Number 1 is the fetal position. Now, what is the station? What is the degree of asynclitism? It's a lateral flexion. And after performing a phantom application, the posterior blade is placed first in order to prevent the loss of station of the fetal head. And then when the sagittal suture of the anteroposterior, then we apply the another blade, the legs anterior, and left blade is inserted first. So these facilities locking the application and deliver it out with a continuous traction can be done. So the proper acclimation is determined by assessing the position of the forceps. Related 3 landmarks are very, very important. The fetal well. Number 1 is the posterior frontinelli, sagittal sutures, and parietal bones. That's another important thing. So the 3 checks for the proper application enduring that. First is sagittal suture is perpendicular to the plane of shanks throughout the length. So this is the point. Number 2, the posterior frontinelli is 1 finger breadth away from the plane of the shanks and equidistant from the sides of blade and directly in front the locked point of the articulate forceps. So it's very, very important how it has been locked, when to place, and what is the difference from the posterior. It should be the equidistance from the both sides from the posterior frontinelli. And if the fenestrated blade are used, the amount of fenestration in the front of the fetal head should not admit more than tip of 1 finger. So another important, we can be able to use only 1 finger should go there. The purpose of these checks is to prevent asymmetric compression of the fetal head. If the rotation is required, it should be performed at this time. Delivery is then accomplished by the traction along with the pelvic curve, the way the pelvis is, and it a correct uterine contractions are there. To perform the flexion of the fetal head with a descent and suction cup and vacuum should be, I'm just putting both the delivery point together, but when to apply the forceps and when to apply the vacuum is determined by the obstetrician. The median flexing point and symmetrically astride the sagittal sutures with the posterior margin of the cum. So I have already talked about this is the posterior anterior part of the posterior frontinelli, and it's a 3 centimeter is a flexion point where we can put it. Now, what is needed for this vacuum? There's a low suction, ensuring no maternal soft tissue trap between the cup and the fetal head. Suction should be increased 500 to 600 millimeters of mercury and sustained downward traction applied pelvic curve, the correct traction. Suction is released between the contraction, and ideally episiotomy should not be given. That's another important point, as the pressure of the perineum on the vacuum cup will help to keep the applied the fetal head. But if it is needed, then the episiotomy can be given. For acute assisted delivery, procedure should be abandoned. Make it a point very, very clear. Number one, if the vacuum cup detaches 3 times, then we should not do it for the next time. If there is any evidence of fetal cell trauma, then another way of putting it. And if it is done, delivery is not effected in 20 minutes. I think 20 minutes is also too much. It's really too much. We should bother earliest for that. And if there is no descent of the fetal head, that's another important point to stop this thing. So there's a one vacuum delivery extractor for the trainers. They can see it. It's a small vacuum, and this is another latest thing by just a manual one by implementation, not this thing. And safe vacuum delivery can be done. More than 36 weeks, 34 to use cautiously. Abdomen 1 with palpable, fully dilated, ruptured membranes, vortex, presentation. Know the position. Very important, the consent, analgesia, emptying the bladder and catheterization. Balloon deflated. We need a trained operator, adequate facilities and backup. Anticipate the complication and train, and for the neonatal resuscitation is important. So just this is a one, I think, very small video. I think it's why it's not moving. So like this. Just by separating the labia and put it, part the labia and use it. Without flexion point, and the most important point, the cervix should not be there between these two things. Vaginal tissue should not, entrapment should not be there. Flexion point. Pressure should be raised up to, this is a manual one. And just a constant traction is very, very important, and to deliver the baby and resuscitation and release the vacuum. Like this. So at the end, just to conclude and make things very simple, what are the confirm the indications of the operative vaginal delivery? First, exclude the contraindications of all operative vaginal, like if there is a CPD or something like that, we have already talked about many more things. So all the contraindications should be excluded. Be aware the type of operative vaginal delivery you will be performing. Number one, review the risk, benefits, and alternative operative vaginal delivery. These are very much. So the consent is very, very important over here. Discuss the potential complications to the mother and the fetus. That's another important point. And ensure all the prerequisites of the operative vaginal delivery have been fulfilled. We have 4 things over there. Number one is maternal criteria, fetal criteria, uteroplacental criteria, and other criteria. Maternal criteria, mother needs an adequate analgesics, lithotomy position, bladder should be empty. Clinical pelvimetry must be adequate in dimensions to size the facilitate the atraumatic delivery. Another important point, verbal and written consent. Fetal criteria, vertex position, fetal head must be engaged in pelvis. Position of the fetal head must be known. Station of the fetal head must be more than +2. Attitude of the fetal head and the presence of caput succedarum is molding should be noted. Uteroplacental criteria, cervix should be fully dilated, membranes ruptured, no placenta previa. The other criteria, very, very important. We need an experienced operator who is fully acquainted with the use of instrument and capability to perform emergency cesarean section if needed. So the facility is also very important where we use the this thing. If we are doing vacuum extraction over there or using the forceps, there should be facility for emergency C-section also there. Now there are 3 points. I think more than 45% rotation is required. Gone are the days. We used then the Keelan forceps, Barton forceps were used. If the vertex presentation and no rotation is required and less than 45% is required, classic forceps, Simpson, Tucker, Macklin, Elliott, or simple vacuum extraction can be done. And for after coming head of the vaginal breech delivery, they use the forceps designed as the Piper forceps. I'm sure that these are the topics, they can be theoretical sometimes, but one should know about it. Now, the problem with the technical consideration, ensure correct placement of the forceps or a vacuum, apply traction in concert with the maternal expulsive force, successful operative vaginal delivery, examine the fetus, maternal perineum, vagina and cervix, and be happy. And if there is an unsuccessful operative vaginal delivery, proceed with cesarean delivery. No place for combined forceps and vacuum delivery. Chalo, vacuum nahi laga to forceps lagate. It should not be like that. So both the things should not be there. And thank you so much. I'm always there for this type of things. And now I think Dr. Anupama is there. She will like to talk something about the expert comments. And my agenda is very simple, that every member matters. So I'm stopping my share and let Anu, you can talk on the, yeah.
Thank you, Dr. Kawita ma'am, for your excellent presentation. It was just superb. Almost all important aspects were well covered and your video demonstration was too good. First, I would like to thank you for including me in this excellent webinar. I like this novel concept of tea time learning. You know, it could prove useful for our postgraduate students in the form of a short revision, and it can be a ready reckoner for young budding obstetricians and gynecologists as well. Now, coming to the topic, in this century, since the last few decades, operative vaginal delivery is now being seen as a lost art. No one, they prefer cesareans over doing this. But you all would agree that it is a useful last minute help, especially when it is full dilated and you can easily deliver by vacuum or forceps. It is really useful. Whether to use vacuum or forceps in certain situations depends on the station of head and more so on the obstetrician's expertise and experience. Each instrument has its own advantages and disadvantages, and whether to perform operative vaginal delivery or not is a tricky decision. In these situations, we must always balance the benefits and risks before making a final decision. Then documentation is also so very important and it should never be forgotten. To conclude, I would like to say both instruments, forceps and vacuum, are beneficial instruments, rescuing more lives and cutting short more pains than any other instrument in the professional armamentarium. Thank you
so much. You have put the words in you have just summarized, and we are really expert on talking on the subject. Thank you so much for being with me today. And I think giving episiotomy or not to give episiotomy, I think I like to have a word from you, but all the literature is talking about while using the vacuum extraction or the forceps delivery, the episiotomy. And episiotomy is a question, like in our country, we use episiotomy in and out for all the patients. But in RCOG guidelines or whatever, or the guidelines of ACA, American guidelines, they don't talk about the episiotomy. I think evidence-based says giving episiotomy is good in our country. I think our experience talks about it. And I think as a medical college professor, you can add a point, what should be.
Well, we need space to apply these instruments inside.